All right, let's jump right in. Have you ever thought about heart disease, like a plumbing problem? Pipes get clogged, and you need the right tools to clear them out. But what happens when those pipes are the most important ones you have? The arteries feeding your heart.
This is a question that millions of people and their doctors are up against every single day. And the stakes couldn't be higher. A blockage here isn't just some inconvenience. We're talking about a life or death situation.
And this is what that puzzle looks like. What you're seeing is an angiogram, basically a live X-ray of the heart's arteries. See that really tight spot? That's the clog, the choke point that's literally starving the heart muscle of blood and oxygen. For a doctor, this isn't just an image. It's a huge challenge that has to be solved, and fast. So, before we get into the really cool tools, we first have to get a handle on the problem itself. Let's get right to the heart of the matter.
The big bad guy here is something called coronary artery disease, or CAD for short. Just think of it as this slow, quiet buildup of gunk. Doctors call it plaque on the inside of your heart's arteries. Over years, this plaque can get hard and make the artery narrower and narrower. That narrowing has a name, stenosis. And that is the root problem that can cause everything from chest pain, which is called angina, all the way to a massive heart attack.
So you've got a clogged pipe. What's the first thing you think of? Unclog it, right? Well, for cardiologists, there's a go-to procedure for doing exactly that.
It's called percutaneous coronary intervention, or PCI. Yeah, it's a bit of a mouthful, I know, but it's the umbrella term for all the ways doctors can open up those arteries without having to do open heart surgery. It's the main way they tackle these dangerous blockages.
So how does this actually work? Well, it's pretty incredible when you think about it. A doctor snakes a super thin tube, called a catheter, from your wrist to groin all the way up to your heart. Then they thread an even thinner wire right through the blockage. A tiny balloon is then inflated, and it just squashes all that plaque flat against the artery walls. And to make sure it stays open, they usually leave behind this little metal mesh tube, a stent, that acts like a scaffold.
Okay, but here's the twist. This is where the story gets really interesting. Just because you can go in and clear a blockage doesn't always mean you should, at least not right away. And this is one of the biggest questions in cardiology today. I mean, if someone's in the middle of a heart attack, the answer is 1,000% yes, you go in immediately. But what about a stable patient? Someone who gets chest pain, sure, but isn't in an immediate crisis. Well, then the decision gets a whole lot more complicated.
This slide lays out that huge debate perfectly. On the left, you have something called guideline-directed medical therapy, or GDMT. For most stable patients, this is actually the first thing to try. And get this, huge studies, like the famous ischemia trial, showed that for preventing heart attacks and death in these patients, GDMT alone works just as well as getting a stent. How about that? The PCI, over on the right, is still amazing for getting rid of symptoms like chest pain, but it's usually saved for when the meds and lifestyle changes just aren't enough.
So what is this GDMT thing anyway? Is it just about popping a few pills? Absolutely not. It is a full-on aggressive strategy. We're talking lifestyle changes, diet, exercise, and a specific cocktail of powerful medicines, all designed to control your risk factors, keep that plaque stable, and prevent clots. It's about playing offense, not defense.
But, sometimes you do need to go in and clear that blockage. And that's when the story really becomes about the tools themselves. And boy, does this one specific tool have a dramatic story to tell. It wasn't designed to just squash plaque. It was designed to physically rip it out.
Get ready for the rise, the fall, and the surprising comeback of directional coronary atherectomy, or DCA. Invented back in the 80s, this thing was a game changer. It had a tiny spinning blade inside to literally shave the plaque right out of the artery. But then, a big study called Caveat I came out, and it showed more complications. And right around then, stents, which were way easier to use, came on the scene, and DCA pretty much vanished. But here's the cool part. It never totally went away. It just found its new role as a super specialized tool for the absolute gnarliest cases.
So what gives? How could it fail in a big trial but still be so useful? Well, the legendary cardiologist Dr. Antonio Colombo just nailed it with this quote. He said, "DCA does not work by intention to treat." What he means is, it's not a simple point-and-shoot device. It requires an artist, a really skilled operator who knows exactly how to use it. The early trials couldn't account for that skill gap. The tool was only ever as good as the person holding it.
Okay, so let's watch a master at work. Here's the problem we're dealing with. A really bulky, lopsided blockage in a super important artery right where it splits. Trying to put a stent there is really tricky. You could accidentally block off one of the side branches. And here comes the solution. Look at that. The DCA catheter is carefully positioned. A little balloon on one side pushes the cutting part right up against the plaque, and then a blade inside just shaves it away piece by piece. It's so precise, and it doesn't stretch or damage the artery.
And wow, just look at that result. It is absolutely stunning. The artery is wide open, blood is flowing freely, and here's the best part, they did it all without leaving a permanent metal stent behind. They just took the problem out.
Okay, now this is the part that just blows my mind. This is the proof. That's not a simulation, that's not a model, that is the actual plaque that was just shaved out of that person's artery. You are literally looking at the problem that was just removed. You just can't do that with a balloon or a stent.
That whole story with DCA really drives home the point, right? You need the right tool for the right job. And today, the jobs are getting even tougher. And the tools, they're getting even more futuristic. Yeah, the new villain in this story isn't just that soft plaque. The biggest challenge now is plaque that's been sitting there for decades and is hardened with calcium. We're talking rock hard. It's like trying to clear a pipe that's filled with concrete. A simple balloon isn't going to cut it. You need a jackhammer.
And for this, doctors have two incredible tools. On one side, you've got rotational atherectomy. Think of a tiny, high-speed, diamond-tipped drill that just sands down the calcium. And on the other, you have this newer tech called intravascular lithotripsy, or IVL. This doesn't drill at all. It uses, get this, sonic pressure waves to safely crack the calcium from the inside out, causing way less trauma to the artery.
And does it make a difference? You bet. A big analysis comparing the two found that using IVL saved, on average, almost 28 minutes of procedure time. I mean, think about that. When you're working on someone's heart, 28 minutes is a huge deal for both safety and efficiency.
So where does this all leave us? We've gone from the big question of if you should even do a procedure, to the wild story of a tool that was ahead of its time, and now to choosing between a tiny drill and sonic waves. It's so clear that this is way more than just plumbing, right? Technology gives us this incredible toolkit, but it's the judgment, the experience, and the skill that make all the difference. Which brings us to the final question. When your heart is on the line, how much does the tool matter versus the artist holding it?